Welcome, everyone. I'm Dr. Carmen Pugliafito, and I'm happy to hear today to have with us once again Dr. Arshad Khanani of the Sierra Eye Associates, Reno, Nevada. Arshad, welcome back to Retina Synthesis.
Always great to be here, Carmen. It's a pleasure to speak with you today.
You've been doing a lot of activity in the area of gene therapy for neovascular AMD, and at the recent angiogenesis meeting at Bascom Palmer Eye Institute, you talked about the PRISM trial, which looked at intravitreal 4D-150 in the treatment of neovascular AMD. Can you give us an overview of the concept of intravitreal gene therapy for neovascular AMD before we get into the trial?
Absolutely, Carmen. I think, as a field, we have great treatment options with numerous different injectable drugs to control disease. But we know that we have a high treatment burden and many patients lose vision in the real world because they don't get enough injections. And all the outcomes show that more injections you get, the better the outcomes. So as a field, we are looking for sustained delivery of anti-VEGF in these patients with neovascular AMD, trying to see if we can control anatomy and stabilize the visual acuity gains that we get after the initial loading doses. So intravitreal gene therapy is exciting because it's an in-clinic procedure, just like an intravitreal injection. And if we can have steady state levels of anti-VEGF, then we can control the disease. So I think the field is very exciting. It was initiated, obviously, in the past with ADVM-022 or Exovac, where we learn a lot about intravitreal gene therapy, the benefits and side effects in the OPTIC study, which we recently published in the Lancet eClinical Medicine. So yeah, a simple in-clinic procedure to have a long-term disease control or actually completely reverse the disease is the hope and goal of intravitreal gene therapy. But since we have great treatments, currently the bar of safety is very high, and I think that's where we are trying to get as a field.
So how does the intravitreal gene therapy create an intraocular biofactory?
So what it does is that it transfects different cells in the eye, whether it's transfecting the retinal cells. And the problem with AAV2 vector is that it does not penetrate the ILM. So if you just have a regular AAV2 vector you inject to the eye, it's going to mainly transfect the pars plana. It's going to mainly transfect the front of the eye. It's not going to transfect the retina itself. And there's numerous publications that have actually looked at that. So for intravitreal gene therapy to work, you need these second generation vectors or next generation vectors where you do this process called directed evolution and modify certain things on those capsids. So now they're able to penetrate the ILM. So the hope is that most of the vector can transfect the retina and the choroid, so retinal cells, the ganglion cells, hopefully RPE cells. So then we can have a biofactory approach that those cells are now getting transfecting and they're expressing protein that we are designing. Of course, with two intravitreal gene therapy program, first one, Exovac, has aflibercept, and 4D-150, which we'll talk about today, has aflibercept, as well as the interference RNA for VEGF-C, which we know is a good target based on the data from OPT 302 program.
So tell us about the PRISM trial.
So the PRISM trial is a phase 1/2 study where we took patients that had previously treated neovascular AMD. We wanted to have a biological activity, so we actually had patients with very active disease. We have covered the phase 1 data in the past. In the phase 2, there's two portions, the dose expansion portion and the population extension portion. So I presented the dose expansion data for the first time because it includes a control. So these are patients who minimum had 6 injections in the last 12 months. So these are not fresh patients. These are patients that were previously treated. And they had to have CST greater than 325 and had to have fluid. So these are really tough to treat patients. And in this part, we randomized the patients 2 to 1 to either receive the higher dose, which is 6E10, which is 3E10, or the lower dose, which is 1E10. So again, pretty low doses of a gene therapy, 3E10 or 1E10, and then comparing it to aflibercept every 8 weeks. So patients came in, they screened, if they had fluid, met the criteria, they receive an aflibercept injection 7 days prior to getting the 4D-150. One thing we did here, Carmen, was the learnings from the optic study. We actually did a slow difluprednate or Durezol taper for 20 weeks in these patients, because we know that we need to control the inflammation that can happen from gene therapy over time. So these patients receive 20 weeks of topical steroid drop. One thing to highlight here is that the baseline CST was 442 microns. So these are very, very high need patients. And remember, this was after receiving minimum of 6 injections in 12 months, many of them receiving aflibercept every month, many of receiving faricimab every month. And then, their mean annualized injection, so actual injection, not just annualized if they're a fresh patient. These are patients that had minimum 12 month of disease. It was around 10 injections of actual. So we know this is the worst of the worst patient population we have in our clinic.
So how many patients were and how many eyes were enrolled?
So 20 eyes in 3E10, 21 in 1E10, and 10 in aflibercept group. There were 2 eyes that were not followed because they had events, unrelated medical events. So we have a good sample size here with a control arm. And I think the priority for me as a clinician is number one question, forget the efficacy, is this safe? Because again, we have great agents. Can we have a safe gene therapy delivered intravitreally? So that was the biggest question I had. And, I know you saw the data and happy to answer any questions on safety. But to me, the safety of this program, where we had no patient restarting topical drops up to through 48 weeks, only one patient needed longer than 20 weeks. This patient was in the 1E10 lower dose group, had 1+ mixed cells, pigment, and some white cells. The PI increased the steroid and they resolved by next time point at week 20, and then they tapered slowly till week 26. So for me, that was the most important thing for me, because intravitreal gene therapy to succeed, we need to have a good safety profile.
So what were the dosage and visual results?
Yeah, so in terms of visual acuity, these are high need previously treated patients. The question was, can we maintain vision? And that goal was achieved. And how is the vision compared to aflibercept? So if you look at the visual acuity at 24 weeks, what we did was we averaged the last 2 time points, because patients were getting aflibercept every 8 weeks, but they had the opportunity to receive supplemental therapy in all 3 groups, meaning 3E10, 1E10, and aflibercept group. So we averaged those 2 time points and we compared it to aflibercept. And what we saw was minus 1.8 and plus 1.8 difference compared to aflibercept in the higher dose and the lower dose. So within the range, so we saw stable visual acuity. And then the CST was the most interesting part, Carmen. Patients in aflibercept had CST fluctuations up to 100 microns. And I'm not surprised, because these are patients that receive actual 10 injections on average, really high need patient population. So we know Q8-week aflibercept is not controlling them. And they were allowed to get supplemental if they qualified the criteria. So we saw that in the control arm, but in the 4D-150 arms, we saw stabilization of CST, and especially the 3E10 dose, the CST was close to the trough of aflibercept injection, which is achieved 4 weeks after. So I think this really showed us that the benefit of sustained delivery in these high need patients, where you have steady state level of anti-VEGF production, can lead to better anatomical outcomes in terms of disease control and reducing fluctuations. So this was really good to see. And I think having these high need patients really showed us that if in this patient population, we're going to be able to control disease, hopefully in a broader patient population, which is the next cohort in PRISM, as well as a larger patient population in phase 3, will be able to hopefully achieve this. So yeah, very, very impressive CST outcomes with a single injection of 4D-150.
So what happened with how many eyes in the treatment groups needed rescue therapy?
I think that's a really good question, right? So back in the day, we thought gene therapy is going to cure everybody. We know that every patient has a different need of anti-VEGF, and our goal is to do two things: either not give them treatment or give them minimal treatment. So when you look at the injection burden, nicely shown usually as a swim lane plot, you see that in the high dose 3E10, there is 89% reduction in annualized anti-VEGF need, which is significant in this patient population requiring actual around 10 injection. Number two is 84% of patients receive either 0 to 1 injection, which is also very, very good because you're taking these patients getting 4 to 8 week injections and giving them only one in 6 months. And then lastly, the important one also is injection free, which was 63% of patients injection free at week 24. So just to remind the audience that they did not get any anti-VEGF from day 0, which is when 4D-150 is given day -7, they get an aflibercept, and then they went 6 months or so, 63% without getting any supplemental treatment, which is pretty remarkable in this high need patient population.
And so the results were impressive, and intraocular inflammation was not a serious problem.
Not at all. I think the 20-week of taper, as I said, there was only one case of 1+ mixed cells in the lower dose where the patient required a few extra months of topical. Everybody finished their taper except for that one patient that went to 26 weeks. There have been no patients up to through 48 week of data that have required, steroid drops again. I think to me that's important because what we have learned with intravitreal gene therapy is you try to taper these patients, and then once they're on BID or Q day, their inflammation comes back. So I think for us to make sure that this is not a chronic problem, you need to have patients who are off the drops and stay off the drops several months after the taper was done. And this was the case in 38 out of 39 patients in PRISM. I think that is super important for intravitreal gene therapy. And I think this is good news for patients as well as the field of intravitreal gene therapy.
What are the next steps for 4D-150?
So the program is moving forward, right? This is safe. It works in this high need patients. The next step is designing the phase 3 program, which is expected to launch in Q1 of 2025. And I'm looking forward to participating in it. So hopefully we can move the field forward to have something available for patients that can be easily delivered in clinic as well as can maintain anatomy and vision for them.
Well, this is a really exciting paper and a tremendously exciting concept of a single intravitreal injection of gene therapy radically altering disease course in neovascular AMD. Remarkable.
Thank you, Carmen. I agree. Couldn't agree more. This is very exciting for patients, and as practicing retina specialists, this could change the course of disease, as you said.
Thank you for joining us, Dr. Arshad Khanani. Welcome back.
Always a pleasure, Carmen, to speak with you. Have a good one.